Chairman. We'd like to thank the organizing committee for giving me this chance. My name is Abdulrazaq. I'm a neurosurgery resident from King Fahd Hospital for the University of Dammam. Today I will discuss with you a case presentation. He's a 31 years old male presented. So this is a 31 years old male presented through emergency department complaining of right cubital fossa mass. It was rapidly progressive over 4 months period, and it was very painful last 3 weeks with diffuse numbness over the right hand. And he had no history of trauma, no history of fever, no history of weight loss or contact with inpatient, and no history of drug abuse, and no significant past medical history. So in examination, it is a 10 by 8 centimeter mass occupying the right cubital fossa. It was tense and very tender, not pulsating, not compressible, and with radial pulsation, not palpable. So neurologically, patient is conscious. Upon the examination was full power, apart from flexing the right elbow to maintain, because of the mass and this pain limited, with diffuse hyposthesia over the right thumb and index finger. So in summary, this is a 31-year-old male who was presented through ER complaining of right cubital fossa mass with a complaint of 4 months period, getting worse over the 3 weeks back, and with no significant history of trauma or drug abuse, and with this examination showed a tender with absent radial pulsation. So my question now, how would you approach this patient? What's your next step?
So did you do examination, motor examination?
Yeah, motor examination is intact.
So motor and the median and ulnar were fine.
Yeah, but only with this pain limited because of very huge mass over the right cubital fossa.
And
So my question is to the resident.
so بس عشان اوضح على ذلك وعندك بس sensory abnormality في الاندكس
right now.
نعم.
Hi, Shabab.
What did you do with the discussion? Go and ask the residents a bit more.
I think the key here in this history has given us is the acute history, and then the so I think you should focus. Can you go back to the history slide? And then I think history in this patient is probably more contemporary than the physical examination. Okay, so he's young person, and go to the next slide, please. If you look at the history is over 4 months period, and basically the keys here are the young age, acute presentation within 3 months of 4 months history, and then also the so one thing is we need to know what is it and what is the sensory finding belong to. So let's start with the sensory finding for the resident. Now, the only thing that we can get from this physical examination here is the sensory deficit. Which nerve is affected here? Patient has lack of sensation or reduced sensation on the thumb and the index. This information we have here, right? Now, he didn't see the volar aspect or the dorsal aspect.
All are intact. Only the diffuse, with the complaint, or the diffuse numbness, but in examination, we had this only two.
But the sensation, they're reduced on the palmar aspect or the dorsal?
Yeah.
Palmar aspect. So which nerve we're talking about? Median nerve. Median. Yeah, it will make sense, right? The anatomical location of this lesion will affect the median nerve. Now let me ask you this. Do you think this lesion is coming from the nerve? No, well, this is for the resident. Do you think this lesion, is it coming off the nerve itself?
No.
Resident? Yes or no?
No.
Well, unlikely, right? Because of the history, because what nerve lesion can be. It's either malignant or a benign nerve lesion, and no malignant or benign nerve lesion will happen over a period of 4 months. So probably it's something else. It's a lesion from somewhere else, but it's affecting the nerve. in the form of pressure. So this is how we rationalize it. Now go to the physical examination. If you look at the physical exam, no, to the local exam of the lesion, it's, can you show us the physical exam? It's non-tender, it's a tender?
Yeah, it is.
Yes, here. It's a tense, tender, but it's not pulsating, but there is a reduction of the pulsation of the radial artery, right? Now, again, is this has something to do with the nerve or with the vessel or not? Now, I'll say the fact it's not pulsating will make me hide away from putting it a vascular lesion. But what do you think? What's the structure in the elbow that could lead to this? Let's make a differential now. Let's make a differential of this lesion. So we agreed that probably it's an extrinsic lesion. It's not from the nerve itself. It's putting a pressure on the nerve. And then now we should think of the structures in the elbow that could form within 4 months and putting a pressure on a nerve. Now, given this progression history, I would have thought of, so he has no history of trauma, I would think of a vascular lesion like a pseudoaneurysm, but with the fact this is non-pulsating, I will not put it at the top of my differential. I will think of the joint and joint capsule, and I will think of some inflammation there, for example, an abscess in that location, given the tenderness, and though it's a long history, 4 months. Dr. Bassam added muscle pathology, but yeah.
Well said. But common things are common. You would think of rapidly growing sarcomas in this region. Anything else would be a better news. Yeah.
So, investigation-wise, patient all his labs are normal apart from high ESR and CRP protein and radiological imaging. So, what do you suggest?
CT.
CT scan or
MRI.
MRI. Okay, for this patient, particularly MRI cannot be done because he cannot go through the tunnel with this very painful. So what we did is a CT. This is his topography with the right cubital fossa mass. You can see here that the bone is intact. And this is the CT scan with contrast. Large, heterogeneous. Can anybody would like to describe it? Can you go to the exit? Anybody from the audience or colleagues?
يا شباب من R5 يرفع يده. R5
Outline the mass for us.
R5 اللي موجودين يرفع يده. بس رامي موجود؟ Okay, Rami, go ahead.
This is an axial image of the forearm and elbow. Is showing what I would describe as in the left picture is a hypodensity in the middle and in the upper aspect also, pushing the muscles. It's like heterogeneous, but mainly hypodense. I cannot appreciate calcification, or this is I think with no contrast, right?
It is contrast.
Or with contrast enhancing.
So this is a large 10 by 15 centimeter mass with heterogeneous component, faint enhancement, cystic component. So any further examination you would like to add?
Would be nice if there can be CT angio.
Yeah. This is what's done, CT angio. This is showed complete obstruction of brachial artery.
Why MRI not done?
MRI cannot be done because the patient cannot enter the tunnel. Because of this cannot fix his and extend his right hand.
What is the consistency of this mass? Yeah, is it hard?
Yeah, it is tense. It is tense.
Consistent?
Yeah. Semi-solid. It's not just.
The skin upper the
It's a heavy.
So this is the radial هنا. بعدين الراديال والألنر are filling, probably with collaterals. لكن في interruption هنا. مش كده؟ You tell us.
Yes, this is complete obliteration of the brachial artery. Distal radial artery is also weak. It's filling and deflect, and here is the ulnar is intact.
Is he symptomatic? Can we have one, two? Symptomatic?
No.
Neurofibromatosis.
So, especially diagnosis, we speak about it. Anybody would like to make it systematic add infectious, for example, just destruction.
So this is mass in the cubital fossa. We have a component of muscle, tendons, bone, and nerve. So I will start with the nerve. This is so we are in the cubital fossa, and we have a component of tendons, muscle, bones, and nerve, plus lymph tissues, lymphatic tissues. I can start with simple things like infection, lymphadenitis in the area, or simple infection in the skin with the collection below it. With the progression over 2 months and it's acute, increasing in size, I can go with highly malignant tumors like Dr. Bassam mentioned, sarcoma, either from the bone or from like neurofibrosarcoma or fibroma. It's less likely with this rapid progression. Vascular, we can rule out vascular malformation from the angiogram. There is no fistula connecting arteriovenous fistula, and it's tender related to nerve or related to muscle. The differential diagnosis.
So, okay, this is our differential diagnosis, as Swell said: abscess, septic arthritis, tuberculous arthritis, cubital bursitis inflammation, traumatic hematoma, vascular malformation, hemangiomas, and also we come to the neoplastic part from the neuronal origin, nerve-shaped tumors, either benign or malignant, tumors of non-neuronal origin, as osteoma and osteosarcoma, soft tissue tumors and sarcomas, lipomas, lipofibromatosis of peripheral nerve, and metastatic tumors. So this patient, he came through ER with this large, very expansile, expanding tumors or mass, and he's very in severe pain and distress, and with this absent radial pulsation. So, how would you approach this patient? What time you will intervene? Is it urgent? You take him to OR directly, or you will wait? Shall we do something special for to see? Is it urgent vascular compromise or just
I would confirm the diagnosis by biopsy.
you will inject the needle.
It's not vascular. We did for him angio. It's not vascular. We ruled out to be vascular. So I can take a biopsy just to confirm the diagnosis, whether it's malignant or benign lesion. If it's malignant lesion, I prefer to take it out.
But you will not consider this absent radial pulsation, severe pain in his, you will not take him to OR for consideration?
We'll see the other side.
He's in pain, okay, but
Okay, so what do we call it?
Ulnar rounds.
Okay, Allen test, okay.
Ulnar.
It was warm. It means that the ulnar pulsation or ulnar supply is intact. So, at that time you have one case, actually, craniotomy with epidural hematoma. So, you will wait for him, or you will...
Question: what did the radiologist say about the content of this mass?
Yeah.
Did the pixels like match a fluid, or did it match actually a mass like a tumor?
Yeah. What they said is a cystic component. They requested actually further MRI, which cannot be done. But for this
Can I
ultrasound,
stop
it's a
with
good
you?
option.
Why can't you do an MRI? Why is it impossible to do an MRI? You can put him to GA and do an MRI.
Is maintaining his elbow like this, he cannot extend.
Why can't he extend?
Because of the big mass and pain.
Okay, if you give him GA and put him in the magnet, can you do that?
Yeah, there's a chance, okay.
No, because you can't say you cannot do it unless he's contracted. But if he's holding it like this, you can always give him GA and put him in the magnet. It's not impossible.
Okay, for sake of time, we should just move a little bit more.
So this patient was taken for, actually for this warm hand, so with that pulsation, checked for emergency exploration and resection through the course of the medial nerve, and large cystic mass encapsulating the medial nerve. It's going all around the medial nerve and associated intimately with the medial nerve. And most of the nerve was seen to be intact at the end of the operation, and the brachial artery encyclographed from the saphenous vein. So pathology, what do you think?
What do you mean? What do you mean the radial artery was cytographed? You mean what was the artery was?
Yeah, it was after exploration it was injured with the mass infiltrating, so destroyed, and so that's why
So the lesion was coming out of the artery, or was it engulfed?
Engulfed with the artery and the median.
What's interesting with the angiogram, a tumor of this size should have abnormal vessels, which it's a good news. Hopefully it's a good news for the patient. I did not see an abnormal vascularization within the tumor mass. So just before you give us the diagnosis, so that's a good news. It does not rule out, malignant lesions, but based on the CT angio makes it less likely. Anyway.
Okay, so what is spindle cell sarcoma? It's a monophasic fibrous synovial sarcoma. So post-op patient function status symptomatic relief, radial pulsation again with no neural deficit, and just for the sake of time I will proceed with further management. I will speak just briefly about synovial sarcoma. It's a common malignant soft tissue neoplasm. Account for 10% of soft tissue tumors elsewhere apart from the intraneural component. And primary synovial sarcoma are very rare, only 22 cases are reported. And rarely, in contrast to its name, it rarely involves the synovium of joints. So it involves the extremity of adolescent and young adults, and it can happen in any location, even in visceral location. Two types, monophasic and biphasic. And although the biphasic morphology is extra about the extremities, but the monophasic component is most commonly seen in intraneural sarcomas. So histological features. Classic monophasic synovial sarcoma have vascular proliferation of gonophobic and hyperchromatic spindle cells, association with collagen and staghorn vascular pattern, diffusely positive for vimentin, patchy expression for epithelial antigen, and by cytokeratin and cytokeratin 7. And this 100 protein and CD57 is positive and variable to cells. And there's some molecular investigation giving advance in this such management of often differentiated diagnosis of such lesion. Radiological features had nodular mass with irregular margins, with heterogeneous faint enhancement associated with calcification and necrosis. And in close inspection, you will see a slight irregularity of their margin and no association with the individual nerve. So the main differential diagnosis in regarding to synovial sarcoma is spindle cell malignant peripheral nerve sheath tumor. Although the morphological features are similar, but they have some differentials. Usually the peripheral nerve are neuroectodermal in origin, but there is a chimal part affecting the peripheral nerve from the neural connective tissue. And the only features offering significant discrimination are the tumor's occurrence with documented neurofibromatosis or plexiform tumor, presence of wiry collagen and stromal calcification in synovial sarcoma, and greater polymorphism, especially in malignant peripheral nerve sheath tumor. immunophenotype. Also, there's a show a considerable overlap with frequent expression of nerve sheath markers such as S100 protein. And CD34 and 99 expression frequently present in the malignant peripheral nerve sheath tumor. And usually prognosis is poor with 50 to 60% 5-year survival rate despite radical surgical resection